So the volume of CSF, we produce about 500 mLs per day, or about 250 in 12 hours. So usually if you have a device that's pulling CSF out of the brain, you don't want more than 20 mLs per hour, because then you're going to drain all the CSF out of the brain, which can have bad consequences, especially if you do it rapidly. All right. So without the CSF, you can see the brain weighs a lot more. Sorry, yeah, we weigh about 1,500 milligrams, and then you got your brain with CSF is very, very light after that. It's just it's more buoyant, right? Instead of it being like a big blob in there, scooting around, and you just get a light fender bender, and then you're done for, right? So having the CSF in there really makes it buoyant, and so that you get less damage to your brain, but also it provides nutrients, it circulates, gets rid of waste. All this stuff gets produced in the middle there. All your CSF gets produced in the ventricles of the brain, not the ventricles of the heart, but the ventricles of the brain. And we produce it in the lateral ventricles, the third ventricle, the fourth ventricle. They all get produced, they're produced in CSF. Most of it's being produced right there in the middle, in the choroid plexus that's there. And you're producing all that CSF, and then eventually it washes around all the brain, right? It's going all the way around. There's a central canal, it goes all the way down the central canal and comes back out the other end, and it's going to, do its thing, right? Its physiological thing. And then it needs to get reabsorbed. So it gets reabsorbed where? At the top of the brain, right? All the CSF gets reabsorbed back into venous circulation. So the dark blue here is the venous circulation, and the light blue is your CSF, right? CSF goes from the subarachnoid space into the venous circulation. This is called the sagittal sinus right here, okay, up top there. So all this CSF is being brought into these little subarachnoid villi, is what they're called. Villi are like spider-like wet fingers. So they're sticking themselves into the CSF, and they're absorbing like a straw all the CSF. So you can imagine if you have a bleed in here, right, a little bleed in there, that can start blocking, those little chambers. And now CSF does not get reabsorbed, and that's going to do a rise in my ICP. My ICP is going to start going up because now I can't get rid of CSF, because CSF volume is one of those three components to our intracranial pressure. Okay, so we absorb this into venous circulation by the subarachnoid villi. And the CSF is like an intermediary, right, between the arterial system and the venous system here. We have CSF in the middle, which is our glymphatic system, right? Sounds like like glamping, right? We could go out glamping. So I have my glymphatic system is what is going to carry away waste, provide nutrients, has a little immuno support, and also has that support of protecting the brain as well. Okay, so that's the idea of our CSF. We want to be able to prevent the blockage of its flow. And can we turn it off? No, you can't turn off CSF production. It's being produced all times. You can't reduce that. You can't reduce metabolic rate and just shut it off. There's no drug yet that will just shut off CSF production. Okay, so we have to make sure we have good, nice drainage in our jugulars there, so CSF can drain once it's in the sinuses over here. And of course, we got to make sure it doesn't get blocked up top here, right? Make sure it's not blocked there, and also make sure it's not blocked in the middle. If it's blocked in the middle, that's a problem, because now you're going to swell from the inside out, right? So that's where we're going next. These are hydrocephalus situations, where you have a communicating hydrocephalus or a non-communicating hydrocephalus. Okay, so I guess that wasn't the perfect segue, because that's the slide after this. So these are the venous drainage I was talking about, right? So we get all these veins that are all over the brain. They are below the dura, and that's why when you get like a subdural hematoma, it's a rupture of one of these veins, these dural sinuses, right? So these are sitting below the skull right here, and we have little fingers from those that are being projected into the subarachnoid space, right? So the subarachnoid space is below the arachnoid layer, right? So you have the arachnoid layer, you have the dura mater, the pia mater, all these different layers of the brain that we'll get into. Okay, so we're putting our little projections in there from the venous side into the CSF right below it, and that subarachnoid space, and we are then absorbing it in there. So a little zoomed in view. So you got your subarachnoid space right there, and you have your sinus right there, right? Your sinus right there. So we're absorbing from point A to point B. Okay, and obviously that can get backed up. And the same way, we absorbed all of our CSF right there on the venous side. We got to make sure the CVP is not too high, otherwise that will increase my ICP. All right, so we got to make sure that we are adequately draining these sinuses. Right, because all these sinuses are going to drain into what? The jugular vein, right? So CSF is reabsorbed, and we go into those venous sinuses, and then it goes to the jugular veins, down to the subclavian, down to the superior vena cava, into the right atrium, right? And of course, the right atrial pressures can be increased if you have increased IVC pressures from the thorax or from the abdomen. Okay, so we got to make sure where the jugular drainage is great. We got to make sure blood is not clogging our drains up here. What else can clog it besides blood are infection. Like up here in the high desert, we have cocci, right? Coccidioidomycosis can cause lung infections, but also can make its way in the bloodstream and then can make its way into the brain and start clogging these pathways here, or clogging the pathways in the middle of the brain. See this little foramina right here, this little pathway, little river between the ventricles, a little narrow canal between the ventricles can get easily clogged with blood or with infectious stuff, right? So jugular venous drainage needs to be great, and of course thoracic pressures and abdominal pressures we mentioned need to be great as well, so we don't have abnormally high ICPs, right? So as we mentioned before, we got to make sure the map is good, and we talked about that with the venous pressures, right? Making sure we don't have low oxygen, make sure the CO2 is not too high, and that will then hopefully improve the map, because that will improve my CPP. And then now we're on the flip side. We got to make sure that we can actually absorb the CSF, right? Because that's the other part of the story. There's the arterial blood supply, or the volume of blood. There's also the volume of CSF. Okay, so you can get thrombosis in the sinus as well, and obviously that's not great. That's going to increase my ICP as well, right? There's congenital reasons things can happen. There's like Chiari malformations where the whole cerebellum sits below the skull, right? And that can definitely impinge outflow, and they need to have a surgical intervention to either fix that or to get a permanent rerouting of the CSF, right? Where the CSF gets produced right here, we can reroute it all the way down the neck and then dump in the thorax, or all the way down to the belly and dump in the belly with a VP shunt, or ventriculoperitoneal shunt. Okay, so more on the compartment syndrome. As we know, we have a diaphragm splits our compartments here. We got our abdominal compartments that have increased stool burden, they have ascites, they have pregnancy. All these things are going to translate the pressures all the way up to the skull, right? So our goal is to improve intrathoracic pressures and intra-abdominal pressures, right? So ascites can be fixed. We can avoid excessive fluids. Fluids have to go somewhere, and they usually, when we are sick, when we're inflamed with the SIRS process, all the fluid likes to go to the belly, right? So everything gets leaky, and all the fluid we give can leak into the abdominal compartment. Okay, and of course, someone has pulmonary pathology along with it, that can be a problem. That's going to increase intrathoracic pressures, and you're already putting positive pressure in the chest with the ventilator in the first place. Okay, and coughing with suction or coughing on its own, maybe we could give anti-cough medications, or we can avoid excessive suction if they don't need it. If they don't have any secretions, we can maybe go to Q4 hours for suction if we need to. Okay, so you can see all the CSF gets reabsorbed into this space right here. What's this space right here? The dark blue space. That's called the sagittal sinus, right? The sinuses, and yeah, they have the arachnoid villi that poke into the CSF space, and that CSF space called the what space? The subarachnoid space, right? Yeah, and then that came from the lymphatic system, right? From the lymph, right? So yeah, the CSF is all going through the whole brain, and then it dumps itself into the sinuses, the subarachnoid spaces, and then dumps into the sinuses via the subarachnoid villi. Okay, so hydrocephalus. So CSF again backed up, and we have communicating and non-communicating. It's a little bit of a misnomer. I think if it's not going from the brain to the system, that's non-communicating, right? But no. So there's non-communicating, we're talking about where it originates. So where does our CSF originate? If we look at a front view versus a side view, you usually always see side views of the ventricles, but really they're called the lateral ventricles. You're producing CSF from the lateral ventricles, and those all drain downward into the third ventricle, right? So they drain downward into the third ventricle right there. And this third ventricle, so here's our CSF being produced, also produces CSF. So this is where your CSF factory is happening. And if we have a blockage somewhere in there, right? We got a blockage right there, or even right there. That's going to cause a backup of CSF. You can't turn off the faucet. CSF is always being produced, right? So we are going to have what's called a non-communicating hydrocephalus. It's called an obstructive hydrocephalus, where we're obstructing the primary flow of CSF, right? So that's our first type of CSF. So our first type of hydrocephalus. So you can see here's some normal ventricle sizes right there, left and right. They're equal size on both sides, look like little butterflies. And then we obstruct flow, inferior to this, right, below it, right, and not anterior, but below it in 3D space. And now that's going to cause my ventricles to start expanding in size, right? So you can see that in CT scan. So you can see we had an obstruction right there with a normal system. Normally it drains from the CSF, from the CSF production centers, the choroid plexus. It drains down into the CSF, into the third ventricle. And if we have an obstruction there, then we're going to start to have a swelling of that ventricular system, right? So that's called an obstructive hydrocephalus if it's blocking the inside of the brain, right? Obstructing CSF flow within the ventricles. So a neoplasm can do that. A clot can happen. You can develop an intraventricular hemorrhage. Whenever you see an intraventricular hemorrhage on a CT scan, that means someone's getting an EVD very, very soon. Because how do I fix all this CSF that's building up I can't stop the production of? Well, I'm going to put a stick in it. I'm going to put a little drain in it, right? An external ventricular drain. A drain that's going to drain the ventricles externally, right? So we're going to take all that stuff that's being built up in there, and we're going to take all the CSF, we're going to measure it every hour, and we're going to then drain that CSF, right? Not too much, not more than 20 mils an hour, because otherwise we're going to drain all the CSF, right? Maybe initially, in the first couple hours, you might drain a little more.
So EVDs are only indicated for that particular type?
So yeah, EVDs are definitely indicated for non-communicating hydrocephalus, obstructive hydrocephalus. Someone has intraventricular hemorrhage or subarachnoid hemorrhage, they're a high risk of getting a blockage of their ventricular system, of the CSF flow, right? This really happens very, very acutely, right? They're fine and they get a clot, and bam, they're confused. They have increased ICP symptoms all of a sudden. They get intractable vomiting. They have pupillary changes, right? So that happens very, very quickly when you block the flow right inside the brain. Okay. So how do you fix this? As we mentioned, you're going to remove the CSF. That's the easiest way to fix it, right? And after a while, after 5 to 7 days or 7 to 10 days of the EVD over here, we then could switch them over to a VP shunt if they still need it, right? So VPS, a VP shunt, is something that can be used if they cannot be titrated off the EVD, right? Your ICPs are still on the higher side. They still have this obstruction pattern. On a CT scan, we might progress them to just doing a VP shunt. They look great, right? Their ICPs are like 5, and their CT scan looks beautiful. Then you just take out the EVD and you monitor them for another 48 hours or so and see if they're doing great. And then they don't need the VP shunt. Okay. So that's the idea behind an obstructive hydrocephalus. The other option is a communicating hydrocephalus, which kind of seems like a misnomer to me. It's like, well, it's not communicating, it's blocked, right? It's blocked, the flow is blocked on the outside of the brain, right? So we're blocking the flow here with blood or infectious products, or yeah, it could be edema, but there's a clog somewhere, right? And yes, a venous sinus clot as well. That venous system, that surrounds the brain, that could also get a clot in it, and that could cause a backup of CSF, right? So CSF cannot get drained appropriately. And it's more insidious in onset, meaning that it's slower in onset. They don't all of a sudden present they're fine one day and the next day they're not. It's like they'll start having headaches, they'll start having increased ICP symptoms, a lot more vomiting, nausea, then a lot more vomiting. And yeah, we have to then eventually remove the CSF, right? They might do it surgically, or they might need a drain at the bedside, right? Place this external ventricular drain at the bedside. Okay, so that's the idea behind our hydrocephalus, is that they are going to be an increase in CSF volume that we need to then fix with hopefully an EVD temporarily, or maybe they'll get through it and they don't need the EVD anymore, or they may need a VP shunt permanently. It has a little battery in there, I think it's a mechanical, has its own little mechanical gauge on it. It's not a battery, but you can adjust it as well. You can adjust the outflow. Like, I got headaches, doc, and they can then adjust the outflow to increase the amount of CSF that's being removed. All right, so the EVD. So it's not the end, unfortunately. You still got a little more time left with me. We got the fixes for the ICP. As we mentioned, we can do like decompressive craniectomy. That is an option, right? But EVD is halfway up that stepwise progression of fixing someone's elevated ICP. And what's it fixing again? It's taking out what? Volume of CSF, right? Not volume of brain, right? It's not talking about volume of blood. It's taking out CSF, right? And when you have an EVD, when you see an EVD in real life, you'll see that they actually are probably taking out a little bit of blood too. That's not the blood they're taking out of the bloodstream. That's the blood that's made its way into the CSF, so it becomes bloody, right? So back in the 8000 BCE, there's evidence of people doing what's called trepanation, where they actually, I got a headache, boss, like, say no more, right? He pulls out a chisel and hammer. Like, what are you going to do? I'm going to fix that headache for you real quick, right? So he's like, bing, ding, 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 ding. And then they got some fluid off and they're like, oh, headache all good? Yeah, it's great. so there's trepanation. That is an option as well. They started documenting it back in like 1700 BCE. That's where they actually had a, they actually painted it. So they had it. They said, "Stay still for me," right? And they're able to actually paint the procedure. And that was our idea of reducing pressure in the brain. Right? They knew the pressure was high in the brain. They probably did have a bleed or something going on, a tumor. But that's not. We don't. Do we do that nowadays? Absolutely, we do. We do what are called burr holes. They're a little more refined. It's more sterile, right? You put little burr holes in the brain to allow expansion. But usually, if we're going to go in there in the first place, we want to do a decompressive craniectomy if need be, right? But before we do all that, we can place a catheter into the brain. Oops, I promise I changed the colors. There we go. We put a little catheter in the drain, and then we can attach it to a little bag to pull out CSF, right? So that's what we do nowadays. We start doing EVDs to measure ICPs in real time. We can see what someone's actual ICP is. Not only does it go to the bag, but it also goes to the monitor, and we get a waveform with 3 humps like that, right? So we can look at the waveform to see if someone's ICP is getting bigger or higher, and we can see if someone's compliance is getting less or getting more compliant. Less compliant is obviously worse. That means the brain's not able to comply with the pressure. So we can measure ICPs, and of course now we're like talking about hemodynamics, right? We're looking at waveform analysis and looking to see if the ICP is good or not, right? So that's the idea behind doing ICPs. All right, so that's the idea behind EVDs. So, like I said, you can get a pressure waveform off it, and you can also pull CSF out, but only with external ventricular drains, right? They actually are going all the way down. They go all the way down into the ventricle. That's actually probably too far. It's probably right there, right? And you're going to be pulling out fluid, a CSF, right? And that CSF might have this white stuff in it too. What's that white stuff on CT scan? That's blood, right? So blood can be pulled out along with it, right? There's other devices out there, like a subarachnoid bolt. There's a little fiber optic thing you can put into the parenchyma to measure the pressure, right? Little bolts to put in there, but they don't pull off CSF. So it's like, well, if I'm going to go in with one tap, right, I might as well get a catheter in there and pull off CSF if I need it, right? Sometimes neurosurgeons want to just monitor the pressure. It's, you have to really convince someone to do that, but usually it's like maybe post-operative for the first 24 hours. They might monitor with a really high-risk surgery. Otherwise, there's some clear indications to place Ventrix, right? These being them, right? You got a traumatic brain injury or the GCS less than 8, we should be monitoring ICP, right? That means if they got to the point where their mentation was that poor, their verbal and motor response was that bad, they probably have a lot of swelling that we need to monitor ICP with, right? You got an abnormal CT scan and a traumatic brain injury, probably you are going to get a Ventric placed or an EVD placed. There's different nicknames for it. So you got the intraventricular catheter, the EVD, the intraventricular catheter, the Ventric is another nickname for it as well, the Ventric, okay? And then we got GCS less than 8 again, and we got a CT scan that may be normal, it's like we can't figure out what's going on, but definitely we start getting some posturing happening. That's time where we need to have a Ventric placed. We have obstructive hydrocephalus is, we talked about that, right? That's when what's happening? That's when CSF can't get through, right? CSF made these lateral ventricles and the third ventricle right there in the middle, right? So third ventricle is right sandwiched between the thalami there, and we got the lateral ventricles. They produce CSF at all times, and if they get blocked flow, right, somehow, that's going to start swelling and swelling and swelling, right? So you can see here that CSF is swelling compared to normal butterfly-shaped ventricles, right? So we are going to place our catheter in there and pull off that CSF while we hopefully fix the obstruction that's right underneath that, right? So obstructive hydrocephalus, a subarachnoid hemorrhage. Subarachnoid hemorrhage is blood in the subarachnoid space, which is where we are absorbing all of our CSF in the first place. If you're blocking all the little fingers that are projecting into the subarachnoid space that pull the CSF from there into the venous system, then you're going to have a backup, right? That's called a non-obstructive hydrocephalus, right? And then we have, tumor can happen anywhere in the brain to obstruct flow. It could cause a little bit of herniation as well. So we also have a edema, intraventricular hemorrhage on CT scan is usually not pathognomonic, but it's like almost 99% chance you're going to be getting a ventric if you have a intraventricular hemorrhage, right? Because if just a tumor or blood or something is compressing right down there, definitely blood is going to start compressing that flow. Or not compressing, but impairing the flow, right? It's going to start clotting off as it just sits there, and now you have this hydrocephalus that develops that will be obstructive, right? So that's the idea behind a ventric. It's going to be able to monitor your ICPs, but also be able to pull off CSF if need be, right? And also it's a method to put in medications like TPA, right? Thrombolytics. We can put in thrombolytics to eat away this clot that's in there. Does the nurse do that? No. The nurse practitioner or the neurosurgeon is one that places the intraventricular TPA. If someone has like coccidiomycosis, for instance, or valley fever that's blocking the flow of CSF in the ventricle system, they give intraventricular vancomycin, right? So that's not something we give. There's going to give a little syringe full of vanco and put it in there so that it little dwells, once a day usually. Okay, so it's a great way to be able to place I thought I put it here, but CSF drainage, but also you give meds through it, right? Such as your TPA and such as your antibiotics is also another pro of a intraventricular catheter. You can't do that with a subarachnoid bolt. A bolt just measures ICP. That's it, right? There's no other things that can happen, and it gets clogged really easily. Can our catheter get clogged too? It can. That's why we want to make sure it's patent at all times. You always want to make sure that it's dripping if it's open, right? Just like an IV piggyback, you have to make sure that we are always draining the brain just a little bit if it's open to drain. When we're weaning patients off the ventricular catheter, they don't need any more. Yeah, we might start clamping it. But in the meantime, you're going to keep draining a little bit every single, definitely every hour. You're draining a little bit, and you can be able to see that it's like dripping. It might be dripping very, very slow, but you can see it in what's called the buretrol right here, right? So if you trace the catheter all the way from the brain, it'll eventually lead to this little chamber right here, all right? A buretrol that will then allow us to measure how much comes out every hour and also let us make sure that it is draining. If it's not draining, that's a call to the neurosurgeon, let them know, hey, it's not draining. And they can say, well, I expected that, or this happened, that happened, or why don't you get a CT scan to see if we got some worsening findings, right? So it's done at the bedside, right? They make a little incision, about a little over the ear, over the eye. They kind of measure, they kind of like eyeball it, literally, right there, right? And they'll use a ruler too. But they'll open it up a little bit. They'll spread up the tissue, and they'll make their first incision, and they'll go straight into the ventricles, right? And they'll usually go on the side that does not have blood in it. If they both have blood in it, you gotta choose which one, right? But if they have like a left hemorrhage bleed, for instance, they're gonna go on the right side, so because that side, otherwise you'll have a lot of blood on that side, right? So, and also the other side, if it has a hemorrhage over here, right? We have a big hemorrhage developing on this side over here. Obviously, it's going to start compressing that ventricle. So it's a very difficult target to get your catheter in that space, right? And as they go through, they don't worry about your childhood memories. They're like, okay, lost that, right? And then now we'll find our catheter. I'm kidding. There's not many memories there. You don't get the limbic system or the amygdala.